Hi guys, so today we'll be talking about evaluating hyponatremia in a patient. So to figure out a patient is hyponatremic, you have to first know the normal range of sodium in the body. This would be between 135 to 145 milliequivalents per liter. Okay? So once we've established the patient has hyponatremia, the next best step would be to measure the serum osmolality. Now, the serum osmolality reflects the amount of solutes you have in the serum. If there's increased amounts, you would have an increased serum osmolality, whereas if you have decreased amounts of solute, you would have a decreased serum osmolality. Okay, the normal serum osmolality is roughly between 275 to 295 milliosmoles per kg H2O. Okay, this is the normal range for serum osmolality. Now, once we figure this out, we can divide it into three ranges. Okay, so where your serum osmolality is less than 280, between 280 to 295, and above 295. Okay, so let's start with the more straightforward ones. So once we have categorized it this way, we can term this hypotonic, isotonic, and hypertonic. Okay, so we're looking at the tonicity. So if it's above 295, this is termed as hypertonic hyponatremia. I will just write Na plus for sodium. Hypertonic hyponatremia. Now, causes of hypertonic hyponatremia include hyperglycemia. So you would see this in conditions like, for example, hyperosmolar, HHS, hyperglycemic hyperosmolar state. You can also see it in use of mannitol. Now, mannitol is an osmotic diuretic that can be used to lower intracranial pressure. Okay? So this would be hypertonic hyponatremia. Now, if the serum osmolality is between 280 and 295, this would be termed isotonic hyponatremia. Isotonic hyponatremia. Now, there are two causes of isotonic hyponatremia. Okay, this would be pseudo hyponatremia, which can be seen in cases of elevated cholesterol, and you can see it in post-TERP syndrome. Now, post-TERP syndrome, what does TERP stand for? TERP is transurethral resection of the prostate. So post-transurethral resection of the prostate, you can see isotonic hyponatremia. So just to recap so far, hypertonic hyponatremia, you would see hyperglycemia and mannitol, and this would be serum osmolality above 295. If the serum osmolality is between 280 to 295, this would be termed as isotonic hyponatremia. This would be seen in pseudo hyponatremia and in post-TURP syndrome. Okay, now let's move on to the slightly more complicated one, but we will try to make it as easy as possible. So if the serum osmolality is less than 280, this would be termed hypotonic hyponatremia. Okay, hypotonic hyponatremia. Now, once we have this, our next step is to evaluate the urine sodium. Okay, we want to measure the urine sodium. So if a patient has hypotonic hyponatremia, we want to measure the urine sodium. Okay, now if the urine sodium, okay, is more than or equal to 20 milliequivalent per liter, we have a certain section over here, and if the urine sodium is less than 20 milliequivalent, we have another section over here. So if the patient has urine sodium of 20 or more milliequivalents per liter, we're thinking that the renal sodium loss is likely. So think about it. If you're excreting a lot of sodium through the urine, you're obviously having renal sodium loss. Okay, whereas if it's less than 20, this is more likely extra renal loss. So which means it's not the kidneys that are losing the sodium, it's something else that's losing the sodium. So this is your next step. So this will be through this you'll be able to narrow down whether this is a kidney problem or it's something other than the kidney. Now, in each of these your next step in evaluation would be to monitor the volume status. Okay? So a patient can be hypovolemic, euvolemic, or hypervolemic. Okay? So this is basically their volume in their body. Okay? So if we're looking at the volume status, so for hypovolemic, reasons for hypovolemic, hypotonic hyponatremia would be renal failure, cerebral salt wasting, and diuretics and hypoaldosteronism. So remember, in hyperaldosteronism, you would have hypernatremia and hypokalemia. Hypoaldosteronism, you would have hyponatremia and you would have hyperkalemia. So you already have low sodium with hypoaldosteronism. Okay, and diuretics, think of diuretics as flushing everything out. Okay, which causes low levels of your electrolytes. Okay, it would cause hyponatremia whether you're using loop diuretics or thiazide diuretics. Okay, causes of euvolemic, which means the volume status is normal. Euvolemic hypotonic hyponatremia would be SIADH, syndrome of inappropriate antidiuretic hormone. It could also be due to renal failure. Now, I do realize renal failure has popped up over here twice. So in a patient that can present with renal failure, such as elevated creatinine, elevated urea levels as well, you have to assess their volume status to determine whether the patient is having hypovolemic, hypotonic hyponatremia due to renal failure or euvolemic, hypotonic hyponatremia due to renal failure. Okay, the volume status would be important in the question. Another cause would be glucocorticoid deficiency. Now, where would you see this? You would see this when the adrenal glands are not able to produce glucocorticoids. Okay? And finally, a cause of euvolemic, hypotonic hyponatremia would be hypothyroidism. So, hypothyroidism is a particularly tricky one to pick up, but an easy tip would be within the question you could see signs of hypothyroidism, such as from just the physical examination and the vital signs, you may be seeing bradycardia, you may be seeing the patient's mood as well, a sort of low depressive mood, patient complaining of cold intolerance, constipation, weight gain, hair loss. Those are kind of things you would see with hypothyroidism. Okay, and lastly, with hypervolemia, okay, so if a patient is hypervolemic, you would see hypervolemic, hypotonic hyponatremia in acute or chronic renal failure. Okay. Now, this is to do with your renal losses. Okay, renal losses of sodium. You'd see hypovolemic, euvolemic, and hypervolemic causes, and accordingly, you would get your conditions that you can easily classify. Okay, so just to review, causes of hypovolemic, hypotonic hyponatremia would be renal failure, cerebral salt wasting, diuretics, and hypoaldosteronism. Okay, causes of euvolemic, hypotonic hyponatremia would be SIADH, renal failure, okay, glucocorticoid deficiency, and hypothyroidism. And causes of hypervolemic hypotonic hyponatremia would be acute or chronic renal failure. Okay, so now let's move on to when the urine sodium is less than 20. If the urine sodium is less than 20, this is most likely due to an extra renal loss. So it's not the kidneys that are causing the problem over here. Again, we would go through our volume status. Okay, so we would have hypovolemic causes. Okay, so hypovolemic causes of hypotonic hyponatremia with low urine sodium. So remember, in the renal losses, the ones we went through earlier were to do with high urine sodium. Now is to do with low urine sodium. Okay, so hypovolemic. Hypovolemic causes include GI loss. So GI loss is typically due to diarrhea or vomiting. Okay, so within diarrhea you have different types of diarrhea. So this would be due to secretory diarrhea. Okay, it can be due to skin loss. So in patients with, for example, burns, with burns you're losing a lot of volume. So when you lose a lot of volume with water, just think of it this way, with water, sodium goes with it. Okay, when you're losing water, you lose sodium as well. So in burn patients who are losing a lot of water, they will lose sodium as well. Okay, another cause would be third space loss. So when fluid is shifting to a third space, this would be in conditions such as peritonitis. Okay, third space loss. And finally, bleeding, which is pretty straightforward. Okay, causes of euvolemic hypotonic hyponatremia with low urine sodium. Okay, you would have to first look for the urine osmolality as well. Okay, the urine osmolality is less than 100. Urine osmolality less than 100. You're looking at conditions such as primary polydipsia. Let me just erase these extra markings. So primary polydipsia, you'd look at excess infusion, so excess saline infusion, for example, and this is due to malnutrition, beer potomania syndrome. Okay, and causes of hypervolemic hypotonic hyponatremia due to low urine sodium. This would be seen in conditions such as congestive heart failure, liver cirrhosis, and nephrotic syndrome. Okay, so just to recap, so if a patient is presenting with hyponatremia, okay, hyponatremia defined as sodium between 135 and 145 milliequivalents per liter, the next best step is to check their serum osmolality. The normal serum osmolality is between 275 to 295 milliosmoles per kg H2O. Okay, once we measure the serum osmolality, we can classify it into three different areas. It can be less than 280, between 280 to 295, and above 295. Okay, so these are your tonicities. If it is above 295, this is hypertonic hyponatremia. The causes would be hyperglycemia and mannitol use. If the patient's serum osmolality is between 280 and 295, this is isotonic hyponatremia. The causes would be pseudohyponatremia and post-TURP syndrome. If the patient is presenting with hypotonic hyponatremia, okay, this is where your serum osmolality is less than 280, your next best step is to measure the urine sodium. Okay, if the urine sodium is 20 or more, which means there's increased excretion of sodium through the renal system, this means there is a renal loss of sodium. Okay, renal loss of sodium. If it's less than 20, this is an extra renal loss. Okay, once we've determined the urine sodium, now we have to assess the volume status, whether a patient is hypovolemic, euvolemic, or hypervolemic. Okay, if a patient is hypovolemic with increased urine sodium, causes would be renal failure, cerebral salt wasting, diuretics, and hypoaldosteronism. If a patient has increased urine sodium loss and has hypotonic hyponatremia and they're euvolemic, you would think of causes such as SIADH, syndrome of inappropriate antidiuretic hormone secretion, renal failure, glucocorticoid deficiency, and hypothyroidism. And if the patient's having hypervolemic, hypotonic hyponatremia with increased urine sodium, you would think of acute or chronic renal failure. In cases of where urine sodium is less than 20, you would think of extrarenal loss of sodium, okay? Again, we would go through the volume status of the patient. If the patient's hypovolemic, losing water, you would think of cases such as GI loss, such as through diarrhea or vomiting, skin loss, such as through burns, third space loss, such as fluid shifting due to peritonitis, for example, or bleeding. If the patient is having euvolemic, hypotonic hyponatremia with a low urine sodium, you check the urine osmolality and make sure it's less than 100. If that's the case, this would be primary polydipsia, excess infusion, or Beer-Potumania syndrome, which is due to malnutrition. If the patient has hypervolemic, hypotonic hyponatremia and has low urine sodium as well, you would think of conditions such as congestive heart failure, cirrhosis, and nephrotic syndrome. Thank you.